Hi,
morning.
Myeong-Ki, how are you doing?
Good morning, Dr. Young.
Good morning.
Yeah, welcome to the Severance Hospital. Actually, we prepared today very interesting left main cases. Before the start of our cases, let me introduce our team. In the right side, Professor Ahn, my colleague, and the next is Dr. Seoul, is the interventional fellow. Okay, Dr. Ahn.
So let me introduce our cases. He is a 69-year-old male with a typical chest pain, recently aggravated. And then he had also a history of hypertension and dyslipidemia. Next slide. So he has no diabetes, and recently he performed the echocardiogram and had no regional wall motion abnormality. And stress test shows a treadmill, shows the ST depression from stage 3. And next slide. And next 4, there are definitely deep ST depressions. So he performed the angiograms 2 weeks ago, and he shows left main has a haziness with some stenosis, severely eccentric stenosis was visualized to left main to proximal LAD. And right side was not a big significant.
We cannot see the angio. If you can play that.
Left, turn slide.
Play.
Previous slide.
Play.
Yeah, we can see the eccentric, very eccentric theroma at the left side. Today, 오늘 angio 보여주세요.
Okay, I will show it in the today's angiogram.
Okay.
Look at the angiogram in the left side. Right coronary is near normal, and this is the apicaudal view. When you carefully look at the left main, it looks acceptable.
Looks hazy, and there's a lot of calcium in the LED and circumflex as well. So the question is whether this can be calcium on the backside, meaning that you need more than one view to look at the left main a bit more carefully.
Maybe calcium and flap.
Yes. Fortunately, frankly speaking, I think this appearance is not frequent, the angiographic finding. There is looks like some plaque or some severe calcification. What it is, we don't know. So my plan is to evaluate the characteristics of some haziness, which was located in the upper side of the left main with the imaging. And if the plaque itself is with a lot of the heavy calcium, the next plan is the load ablation for the debulking and crossover the stent. That is our initial plan. Okay, let me ask about the opinion about the panelists from about this treatment strategy and angiographic file.
Can you have another view, another projection of angiography, maybe?
Next.
Next view.
This is a spider view.
Yeah.
In the left side, there is clearly see in the some. Before the injection of the dye, you can clearly see the distribution of some calcium. Therefore, that is the possibility of the calcium. That is maybe the possibility. What it is, we don't know still.
Yeah, so the calcium sort of spiral around the proximal LED and to the left main. So again, yes. I think imaging will be very helpful to delineate the calcium distribution as well as the size of the lumen. Any thoughts, panel? Anybody would do anything different at this point, or start to rotablate? What would you do?
I think the intercoronary imaging is the way to go for to get a real appreciation of the distribution of the calcium there. We still have in mind that there is this pathological stress ECG, so there probably has to be a reason for that, and probably it's the left main.
Okay.
Most likely, aerial view might also be helpful because there's a lot of calcium in the middle part of the LED as well. So I think that might be another significant lesions there.
Yeah, so an LAU cranial may be helpful to take a look at that as well. But, Myeong-Ki, what are you planning to do next?
Actually, I don't want to touch the other lesion. At this time, I want to focus in the left main alone. And actually, when you look at the RCM of the LAD, because of the calcium, actually the remaining part of the LAD might be a very narrow. 전의 이미지 보여주세요. When you look at that in the RCM of LAD, quite narrow. So personally, I think that the angiographic appearance, because of the heavy calcium, cause some severe narrowing in the LAD RCM. It results in a typical angina symptom in this patient. That is the hypothesis of this patient. Anyhow, we have to evaluate the characteristic of the plaque with the imaging.
Yeah.
Any other opinion?
Anybody would consider doing FFR and just sort of say, well, if an FFR is negative, not do anything. The stress test obviously concerning for the left main. I think the interesting extension of this is that, we've talked about using FFR angio to sort of see whether lesions are physiologically significant. This will be a difficult one because, I'm not sure how the quantitative angiogram will actually be able to figure out how tight this is and give you a number.
Yeah. How about to use the arrows? Yeah. Arrows on the OCT to look the lesion?
Yeah, and I agree with Alan that for this patient, we have to answer two questions. First is what is inside the left main, and second is what is the significance of the diffuse calcific lesion in the proximal to mid portion. So in this scenario, I would do both imaging by IVUS and also by FFR, and with a pullback of the IFR. Because there is still a relatively good landing zone in the most proximal LAD, if the proximal to mid calcific lesion need not be dealt with. So I would like to assess both the functional significance and also the anatomical significance of the left main lesion.
Okay. So you're ready to show us some imaging?
Yes, we already done, and before that, I wanna listen to the other opinion from the other panelists. Actually, the patients suffer from a typical angina in outpatient clinic, and we already demonstrate that the objective ischemia by treadmill test. So personally, we don't need the pressure wire in this lesion to evaluate the severity of the left main. If there is no other opinion, okay, my colleague, Professor Jung-Sun Kim, will show you the OCT and IVUS images.
Yeah, this is a JS Kim from Severance.
Please show the OCT image on the screening.
At first, I would like to show OCT image. Here is a pullback, as you can see. Here, this is the proximal LAD, and to the circumflex here, around 3 o'clock, and here is the left main. There is a calcified nodule and protruding calcified nodule, as you can see, which is one of the bulbar plaque. But there is some limitation to see the proximal left main lesion because of as you can see, there is a little clearance of the contrast in this image. So it is not so acceptable to measure the proximal lesion of the left main in OCT. But however, we can check the plaque characteristic here. There is a significant calcification, and also there is some protruding calcified nodule here, so which is a bulbar plaque. So we also do the IVUS at the same time. So here is a pullback from the proximal LAD, and vessel size around 5, 0, and lumen diameter is around 4. So here's approaching to the left main here. So there is we can check the exact number of the lumen area at the proximal LAD around 4.6, and proximal left main is around 6.8. So proximal reference of the diameter is more than 5.0, and lumen diameter around 4.5 millimeter.
I'd like to express the value of the imaging of this patient. Actually, we intentionally evaluate the lesion plaque characteristics of the OCT. However, in this lesion there is some contrast within the lumen, so we cannot clearly discriminate or measure the actual lumen area. So we switch it with the intravascular ultrasound, and then we can measure clearly the ostium of the LAD, and it was measured by 4.57. The IVUS. Actually, I expect that the area of the LAD ostium more smaller. However, the IVUS finding is 4.57 at the ostium of the LAD.
So,
any other opinion about based on the two imaging study?
Actually, after looking at the IVUS image for this patient, two things in my mind. The first thing is we need FFR to measure this. I'm not a big fan of the FFR, but the ambiguous lesion,
we can do that.
The minimal area.
Pressure
so
wire.
maybe FFR will help us to decide straight. The second thing is that the rotablator won't work. This lumen is still large, and the debulking efficiency is very low in this left main lesion.
So Professor Hong, what was the result of IVUS finding of haziness on left main?
Haziness by the calcium is
only calcium.
in both, yes, OCT and IVUS. And it makes some smallest narrowing at the proximal LAD. So, anyhow, before preparing these cases, we do not prepare the pressure wire itself. The reason why, patient symptom is a very typical angina, and we already got achieved the objective ischemia by treadmill test. So personally, I think we don't need the additional pressure wire measurement. However, the area of the LAD ostium is more larger than my expectation.
So I think the next step is to define which lesion is culprit for myocardial ischemia, left main or the diffuse distal lesion, proximal to mid lesion. Yeah.
Personally, of course, the left main.
No evidence we have. No.
Any other opinion?
This is stage 3. Stage 3 ischemia, so it cannot be just left main. If it's left
Pressure
main,
wire.
normally it's stage 1 or stage 2, but stage 3
Did you go far enough in your in your IVUS to look at the LAD as well, Myeong-Ki?
이거 안 들려.
Did you get a look at the calcified area of the LAD?
왜 이렇게 끊어졌다 들렸다 하죠? Sorry.
Sorry. Meaning, did you get far enough in to look at the LAD itself in terms of using IVUS? Because these things sometimes can fool you on angiogram. Just like the left main is pancaked, it's oval, and that amount of heavy calcification in the LAD also could hide many lesions that you may not be able to pick up angiographically. So since you're there, certainly to see whether your ultrasound can go in and take a look at that heavily calcified LAD as well.
Okay.
And I'm a little bit uncomfortable to measure the MLA in the bifurcation like this on the screen. Actually, this is a polygon area, so you need to go distally, a little bit distally, to measure the MLA.
You mean they want to measure in the mid LAD lesion, right?
No, the proximal LAD ostium may be the smallest diameter lesion, more severe lesion. So measuring MLA like this, is it correct?
Dr. Kim? Dr. Kim, please answer.
So, I mean, your measurement can overestimate the severity of the lesion, I think.
A little bit, but adequate, reasonable, acceptable.
Are you going to IVUS the circumflex as well, Myeong-Ki, or?
Okay, I will do it for you.
Just because it's a very so narrow angle that what is the plaque distribution, that area that when you're going to, I presume you're going to treat the left main into the LAD is what is the, what is going to be the behavior of the origin of the circumflex, even though you see a little bit of the circumflex on your IVUS, but I think in the left main it's always good to look at both to make sure that what is the plaque distribution at that time. It looks like it's away from the circumflex, so you'd probably be okay, but I think looking at it will be helpful. Any comments while they're trying to get the IVUS?
As you request, I will do the OCT at the proximal circle with the IVUS, not OCT.
Yeah, so the left main OCT is a problem because obviously it's very difficult to clear all the dye, so we tend to not use that.
This is the IVUS images from the circ. Go ahead.
Yeah, pull back from the circumflex. The vessel area, vessel diameter is
the middle portion of the circ and approaching to the proximal circ.
So negative remodeling here. There is a plaque between 9 to 3 o'clock. Also vessel size 1, 2, 3, 4, 5. Vessel size is around 5. It's approaching to the left main. There is a mild plaque.
The ostium of circ.
Yeah, ostium.
Now coming the
LAD. To LAD, yeah. But circumflex is not a significant lesion in this IVUS imaging.
It is not so severe in the proximal circle, including the ostium of the circ. Okay, let me check another view. Let me check the angiogram in the mid-LAD.
So presume we're going to fix this. What are the panelists, everybody, how are you going to approach this lesion? You fix the left main into LAD, protected circumflex in a provisional way, or what would people do?
If I fix it, the left main is a crossover. And then if there is some compromise of the ostium of circ, and then provisional stenting or balloon dilation, AP cleaner. Okay, Angio. Yeah, Angio. Nitro. There is some narrowing in the mid to distal LAD, but actually this is not at our interest. 주말은 앞으로죠.
In these very calcified lesions, sometimes you focus on one lesion, it's actually something else is causing some of the ischemia as well. So I think it's important to make sure that when you finish, it'll be interesting to see how the FFR is, for example. Obviously, I'm not asking you to put another Y, but a lot of times you think it's ischemic in one location, but it's actually somewhere else. It's also additional narrowing that gives you the problem. Okay, maybe we'll go back to the left main. How would people fix this left main? Chris, any thoughts? Chris Wong?
Well, it's quite a big calcium spur there. So the question is not actually, circumferential. So if you actually quite easily deploy a stent, the debulking I don't think is really that necessary. But you need to sort of depends on the sizing of the stent you're going to, because there might be some discrepancy between the left main and also the LAD. So I think that is an important point.
I agree. Actually, the lumen space for the spared in the LAD ostium, so even though I do the low ablation, maybe the amount of the low ablation debulking is very small.
Yeah.
Okay, this is the IVUS images and the far to the
LAD.
mid to LAD.
Yeah. There is some narrowing here.
That's it?
Yeah. There is the little plaque button, this area, middle LAD.
Okay, we
and
did.
the size is a 3.5, and there is a little plaque button here also. It's getting larger. Yeah, there is some plaque button here. There is some attenuated plaque. Yeah, between 9 to 3 o'clock, and there's a calcified plaque here.
Is that among the calcified lesion, the proximal part? That these are small, small lumens.
Right.
Yeah, there's some calcified lesion here. This is a calcified plaque was shown. Where is it? So here is the LAD. The circumflex, This is the left main. Yeah.
Okay. Please measure in the proximal to mid LAD with a severe calcific lesion.
So do you think we need to fix the further down in the LAD? All the panelists, you saw the IVUS, Michael?
Well, my appreciation would be to go now, based on this IVUS image, to treat the distal LAD lesion. And then what I would do is an IFR pullback from the very distal LAD to the left main to see whether I do have a jump in the curve, especially at the orifice of the ostium of the LAD. I don't think so. There will be something.
I think with that stress test being that relatively positive, and the left main lumen is not that bad. You always have to search for other lesions that add together, give you the bigger picture. So I think that's very helpful to really think through it and not just get caught by the left main and just say that's it. Because if you fix the left main, the patient will still have symptoms, and you end up not getting a complete revascularization, if you may. Because this lesion may not be that type, but on top of its 4.5 left main, it certainly could do on top of 3.0, for example, here in a sort of a serial lesion fashion. Even the circumflex have a little disease as well, maybe not as bad when you pull back. So in the proximal mid portion.
Long lesion in the middle LAD. So I think measuring the minimal lumen area is not used for decision.
Also, length plays a big role in terms of pressure drop.
But we have no definite criteria. So I think measuring the pressure is useful to decide.
So as Michael said, a pullback of some sort of physiological, it'll be very helpful in that regard. But I think you need to treat what you think is anatomically narrow first, and then maybe go from there.
IV adenosine 중에. Okay.
So minimal lumen area is a 2.9 at the middle LAD. There's a 2 parts. There is another narrowing part here. Yeah. It's a 3.23. So it's a minimal lumen area around 3.30 in this patient for the LAD lesion.
The interesting thing about calcified lesions is like treasure hunting. You find different things as you kind of go and dive deeper into different area, and you find lesions here, lesion there, and then you have to be prepared to treat more than you think in the beginning. So are you, Myeong-Ki, are you using a set of pressure wire? What are you planning to do?
Yes. Yes.
IFR, or what wire do you have?
This is a simple pressure wire. Actually, my earphone is a very serious problem. Okay, 기다려. 자, 아니 기다려. 이퀄리제이션 해주세요.
Can we see the pressure wire tracing on the screen as well?
예, pressure wire 좀 보여주시게 해주시고요.
Pressure wire.
Okay, now we do the pressure wire equalization.
Equalization in LAD? wires and
pressure
sensors
sensor
and
should
LED.
be more proximal, I think.
Equalization?
Is that okay?
Dr. Hong, you should look at the location of the sensor.
It's in
Now
the
it's okay.
correct position.
Okay.
That's it.
Yep.
It's okay?
Yeah.
Okay.
Equalized, yeah. So you can look at PDPA then, right? Not necessarily IFR. And
I think it is a perfect case for FFR in my mind. So intermediate lesion, actually the FFR result is intermediate, but this is ambiguous lesion, indeterminate lesion, perfect case for FFR, I think. And also the long lesion, multiple lesion is very good case for FFR, indication for FFR.
So far it seems like a PDPA of 0.9,
Main screen
0.89.
Yes. So baseline is 0.9.
0.9.
Okay. 해주세요.
Will people do a FFR pullback, or do people just do a PDPA pullback?
Okay. When we achieve the maximal the hyperemia, we will do that.
Okay. So you're going to do an FFR pullback?
Yes.
Okay. Are you giving intravenous adenosine, intracoronary,
yes,
intravenous?
of course.
Okay. Tell us when you have to presume you started, and you can see it, the pressure dropped to 0.7, or going further, 0.67.
Okay. I will do the pullback.
Yep. That's very helpful to see simultaneously your pullback and the pressure tracing. So still 0.75, 78.
So now you cross the lesion.
Yes.
So there is that's a pretty much a sort of a centimeter or so of jump there. And now the left main ostium, so forth, is about 10%, so 0.90, 0.91 or so.
Okay. Now we're coming left main. Okay.
So the worst number is 0.70, 0.69 or 68 or something like that, right?
Main jump was the actually medial AD rather than the left main.
Yep.
But I think that because of the mid-area lesion, the significance of left main is underestimated in these cases. So you can decide.
So the mid-LED is significant, but it's not, not a FFR 0.4 or 0.3 that typically don't influence your left main interrogation that much, meaning left main could be a little bit more, but not like be really significant, if you may. So if you want, you can certainly fix the mid-LED and then repeat FFR if you want to be complete, or
mid-area.
I think the mid-LED is where your 0.69, 70,
I will
30%,
try to fix
40%.
the mid-LED portion first, and then try to do the pressure measurement again. Okay?
Okay.
It's good strategy. Yeah.
So I think the imaging and the physiology was very helpful to sort of switch your strategy a bit. Otherwise, it would be fixing left main, go home, and nothing much changed for this patient.
자, 앉아. 자, 3호. 물론 3호.
So about 20% of the pressure drop is in the mid-LED, and about 10% is in the proximal part of the
Right.
close to left main or osteo-LAD or so, maybe 25, something like 20% or something. So with an FFR 0.65 per 68.
Right.
So what is your plan? Balloon and stent?
Yes, sir.
Okay.
Inflate.
I see a little waist there.
Deplete. Okay, inflate. More. Okay. 다시 한번. There is some severe calcification, and then there is some indentation. More. 자,
What size balloon and what pressure?
It's a 3O, 20,
16?
20, 20.
So 20 hemispheres?
Yeah.
Yes.
Compliant or non-compliant balloon?
No, non-compliance.
Okay.
Okay, let me check the angiogram.
So can I ask why we're not starting at the main lesion, distal, starting at the middle? Lesion was very distal.
Looks significant, but the main pressure drop is a medial AD. I want to fix it, medial AD first, and then check it, the severity of the left main with a pressure wire again.
If this patient were my patient, I'd like to fix the very distal lesion and put the medical therapy. Put the patient on the medical therapy. So we need to consider the cost and the benefit actually. So calcified intermediate lesion in medial AD, even if FFR is significant, so I'm not sure.
Personally, I agree with Dr. Kwon's opinion. Usually, I want to fix it at the distal location of the lesion with a stent. Angio. 자, 3O. 28.
How long are you covering the diagonal branch all the way down to the other diagonal branch? That's kind of the length of the lesion. Where do you want to cover? How do you want to cover it?
It's some difficult question. So, what is your recommendation? If I fix to the normal, actually the stent length to be long.
It really sometimes tells you with calcium it's quite difficult to judge what is the normal area because on one view could be normal, could be abnormal
제일 긴 게
as
얼마예요?
well. I would err on a little longer stent.
디스탈까지? 아니야, 여기.
Is there some vasospasm beyond the diagonal?
3O.
Maybe a little nitro as well. Myeong-Ki would
Okay.
be helpful too.
Okay, good opinion. 나이트로 먼저죠. 잠깐. 그렇죠. 자, 왼쪽. This is the angiogram after the nitroglycerin. Okay, give it to me. I will deploy the 3038.
So your plan is put the stent from the distal to second diagonal to the origin of proximal to first diagonal?
I'm not sure. Actually, just a single one stent cover the whole region. I'm not sure. A little bit shorter.
Oh.
3-0, right? Is that?
Yes, 3-0,
Yes,
30. So
yes,
38.
of course. Test it.
Come back a bit, yeah.
Right.
Yep.
자, angio. 조금만 더 나오자. A little bit more.
Yeah.
Okay. Go. 16.
What stent is
Science.
science?
Hope that's just a
16.
bubble. Yeah.
So,
Angio.
is this your intended proximal landing zone, or would you like to go further proximal?
High pressure. the balloon 주세요. I will do the additional balloon. And then check it with the pressure wire again. 하이 프레셔하고 엔저 찍고 ACT 체크하자고. (16) 18 디발론 18 20 balloon.
So the same 3O NC balloon?
Yes.
Over the 20 atmosphere. 20.
balloon. 자, 프레셔 와이어 준비해놓고.
Usually in the diffuse lesion in the LAD, even after the stenting, the FFL was not so much improved. Is that right, Dr. Tak?
Yes, usually it is very difficult to have good FFR in this kind of. It is not so long, but usually it's very difficult to get FFR more than 90. So I have question to Hong. So you expect FFR more than 0.9 or less than 0.9?
I'm not sure. The main reason of the stent, the medial LAD, is to evaluate the hemodynamic status of the left main.
Would you like show us the angiography of this hypertension?
Okay, let me check it again. Nitro. Pressure wire.
Dr. Hong, you don't want to touch the distal lesion, the very short, non-calcified simple lesion? You don't like to touch that?
Actually, I'm not sure it's maybe some wire bias or not. I'm not sure. So, anyhow, at this time, this is my interest. First of all, we have clarified the significance of the distal main lesion with the pressure wire.
As you see here, we have a lot of guidance, OCT, IVUS, FFR. Still, we are not sure. So clinical judgment is most important. So you are demonstrating the very nice case for that.
자, pressure wire 다시 주세요.
So Myeong-Ki, you're going to do the repeat in FFR now? Is that what you're planning? Yeah, I guess so, yeah. It would be good to look at the original angiogram and see that lesion. That's a little, maybe again, could be wire biased. Whenever you have calcified lesion as well, sometimes make it difficult. Any guess what would be the FFR beyond the stent? Not maybe past that little lesion distally, but as you were saying, that's not likely to be anything better than 0.90, right? That would be pretty hard.
저걸 다시 할 필요
And
있나?
the left main has 10% already, so.
I expect around
Based on
0.8.
our data.
잠깐 기다려.
0.8 to 0.82.
Okay. Any higher? Anybody bet any higher?
Lesions which require more than 30 millimeters with calcified lesion, it's the possibility we can get
equalization
for more than 0.90 is around 50. Even with very repetitive, aggressive high pressure dilatation.
That's LED. Yeah.
LED.
Did we do equalization again, or we just?
Yes, again.
Okay, sorry.
We did.
Okay.
Alan, I think if he's withdrawing the second wire,
okay,
he gets rid of the wire bias when he's just doing the pullback of the pressure wire. It gives you real data of the distal lesion.
자, 시작하죠. Baseline is a point. More lower. Now we are infusion.
And you do pullback as well again?
Yes, I will do that.
Thank you.
Now we are doing the hyperemia by the IVUS intravenous adenosine infusion.
Must wait. Okay. Yeah.
I will try to pull back it.
Here, A2, right.
Yeah, it's moving around a bit. Yeah, each year.
Distal has some problem.
This is a distal lesion.
Initially, the distal to the far distal lesion 0.76, distal to the far distal lesion 76, and just distal to the stent A2, right?
Okay. Done. Okay.
So what do you think are the FFR numbers? We were jumping around a little bit. So what do you think at hyperemia, what's the number here? Because there was like 0.86 and suddenly it would drop to 0.70, 0.68 or so.
Yes.
So result shows us the pressure gradient means the delta FFR across the stent is 0.1 and from the proximal stent to the left main is 0.1.
Personally, I think it's based on the pressure wire measurement. The plan is the fixed the distal main, including ostium, proximal LAD. Dr. Tak, is correct?
So you want to dilate? You want to fix the proximal LAD lesion?
Based on the pressure wire measurement.
Pressure wire measurements, I think we can go to medical therapy.
I think the problem is the distal.
So we all a little
if the
concerned.
pressure wire measurement is above the 0.8, I think it's just let it alone.
Yeah, I think you need to. Treat the far distal lesion and leave the left main lesion alone. So you cannot get a lot from the stenting the left main to LAD. This will have some risk, and the long-term outcome is not very good, and no worth trying to treat the left main to LAD bifurcation.
So, in the IVUS review again, can you show us the IVUS image? This is a distal LAD lesion. Best size around 3.0, and this part is narrowest point is 2.1 square millimeter for the minimal lumen area. So I think this part is maybe possible to drop the main FFR. So I think this is another option to treat this area.
Where?
Yeah.
Distal,
yeah. In the IVUS image.
It seems like the left main is not really a big issue. What do people think? Meaning that, it is some pressure drop there, but not enough maybe to
at least we need to look at the distal LAD.
Right.
But before we intervene that, I would suggest to take a comparison with the baseline angiogram to see how much is contributed by the guide wire itself.
And the wire is not difficult enough. You can actually pull it back and take another picture and see what it looks like, get some nitro, and decide whether you need to fix the LAD then.
And also the delta FFRs across the stent, even when we calculated with the stent length, 0.1 means stent under expansion.
다시 한번 NT 줘봐.
There's some evidence from Tanaka's paper or our.
It could be created by those,
the pseudo lesion.
Pseudo lesion in that part. So I would just pull it wide back to leave the soft part there and give some nitro and then wait a bit. And then maybe that's FFR was created by that problem. Oh, wire's back.
자, 다시 해요. 다시죠. 다시죠. NT죠.
Is nitro given?
Yes. In my view, it looks like some accordion effect.
So you don't believe the FFR?
Let me check it.
FFR was abnormal. So
there was a pseudo lesion there created by the first wire, so it's hard to know what the FFR
So
means.
FFR caused abnormal because of the wire?
Pseudo lesion created. So
I think it's a distal lesion is not the issue.
Not an issue.
Not the issue, I think. So I calculated the transcend FFR is 0.88. So it is unsatisfactory stent expansion.
So you can post-dilate the LAD stent a bit more, and leave the left main alone?
Main, I think, is a little bit as it is.
Anybody, let's say the distal lesion is like this, probably can leave alone for the time being. And then anybody would treat the left main, leave alone, and come in? Michael, you fix the left main or leave alone?
No, I would leave the left main alone, primarily based on the IVUS cross-sectional image data.
Okay, everybody wanted to leave it alone in the left main. And what about the distal LAD?
I think it's not the issue.
Therefore, leave it alone.
Small territory.
Right. Okay. I accept the opinion from the panelists, the opinion. Okay, leave it alone, left main and the mid LAD. Any other question?
Repeat a stress test when she's when it's ready.
Can I ask you, Dr. Tak, you are a FFR specialist, so if there is according with the wire bias, what is the finding about FFR? Actually, FFR will change by the wire bias?
What?
Accordion effect like this.
So
FFR is different?
FFR decrease.
Decrease?
Yes.
It's a very, very, very short lesion and eccentric.
It is very, very tight. Even it is very short. So, so I think if you have accordion effect distal to the your culprit lesion, I think it is better to avoid the distal lesion and place the flexible part of pressure wire on the and and measure the FFR. I recommend. And sometimes you can give repetitive vasodilatation, nitroglycerin.
Okay, so any post-dilatation, Dr. Tak suggests more aggressive. You don't have to be, but you suggest do a little bit more dilation in the stent, right?
If Hong wants, I think it's not patient. So you have
I already did it.
You have another case for presentation? No, this is case. So, thank you very much, Hong, and it was wonderful demonstration. Thank you very much again. Yes.
Thank you.
Great, really a case that is, illustrate all the imaging and FFR, sort of the dilemma in terms of sorting out what lesions is the responsible part. So we're going to go on to the feature lectures, physiology. It's my pleasure to introduce my colleague, Dr. Bill Fearon from Stanford, to talk about angio-guided versus FFR-guided PCI. Bill?
Thank you, Alan, and thank you, Dr. Tak. So I'd like to talk a little bit about angio-guided versus FFR-guided PCI. And first ask the question, why should we perform coronary physiologic lesion assessment? And as many of you know, I think we've learned over the years that we can't rely on the angiogram, that the relationship between the diameter stenosis and FFR is not a very close one, and we see this huge scatter, and we really need more fine-tuning with the FFR to figure out which stenoses are causing a problem. Even if we look at left main, and this last case was a good example of that, you get a variety of opinions regarding whether or not a left main is significant based on the angiogram alone, and then when you look at the correlation with FFR, it's very poor. Some have argued that we should be FFRing all vessels, even if we don't see obvious angiographic stenoses. That comes from this study here of 200 patients where they did FFR of every vessel. And even vessels with minimal or no stenoses, you see there are some lesions hidden there with low FFR values. Some might argue, well, I don't need FFR because I can rely on the stress test to guide me. The issue is that in many cases, at least in the United States, we don't have stress tests performed prior to the patient showing up in the cath lab. In addition, particularly in multivessel disease patients, when a stress test has been done, it can be misleading, and you can see normal results in patients who have low FFR, or you can see abnormal reversible defect in a patient with normal or non-ischemic FFR value. Another reason to do physiologic assessment is because multiple studies have now shown improvement in outcome. We're all familiar with the FAME-1 trial, which showed improved outcomes with FFR-guided versus angio-guided PCI, extending out to 2 years with lower rates of death or MI. And that this leads to significant improvement in resource utilization, lower cost, improved outcomes. This is an interesting study that we just published looking at data from FAME-1 and FAME-2 and looking at the change in quality of life based on the FFR value before PCI. So all of these patients in the 3 columns here received PCI, and you see that those who had the lowest FFR before PCI had a significant improvement in their quality of life. Another way of looking at this is looking at the delta FFR, so the post-PCI FFR minus the pre-PCI FFR. This is a reflection of the amount of relief of ischemia. And again, the patients who had the greatest post-PCI FFR had the significant improvement in quality of life compared to those who had lower levels of delta FFR. And I think in relation to the Orbita trial and concern that there may be a sham result or a placebo effect from PCI, this argues against that because all of these patients had PCI. So you'd expect if it was a placebo effect, a similar improvement in quality of life across the board. But you see this direct relationship based on the FFR value. We also have some hard endpoint data now. This is 5-year follow-up from the FAME-2 trial showing lower rates of MI when PCI is performed guided by FFR versus medical therapy alone. In addition, there was this meta-analysis of 3 trials where FFR-guided PCI was performed, over 2,000 patients, stable or stabilized coronary disease, and you see significantly lower rate of death or MI in FFR-guided PCI compared to medical therapy. Also, although the costs of PCI up front are higher, of course, than medical therapy, over time there is equalization. So by 3 years, there's no difference in cost because the medical therapy patients have events. Now, some would argue, too, that we should be doing it after PCI. These are data showing that if you have a low FFR after PCI, you'll have a higher event rate during follow-up. One can look at it by saying, well, why wouldn't you perform coronary physiologic assessment? What concerns do people have? And one of those is how reproducible is FFR? But we looked at this in the contrast study of over 700 patients where FFR was measured twice at the beginning and at the end, and you see that there was really good reproducibility. Even the resting indices, non-hyperemic pressure ratios like IFR, have pretty good reproducibility, although there is a little bit more scatter. And there is a clear relationship between FFR and adverse events. The lower the FFR, the worse the events. But you see that even the high FFR, there is some event accrual over time. These are patients, all of whom were treated medically and had FFR value measured initially. And so some would argue, well, we should do PCI in order to avoid these events. But the issue is that PCI, even with current generation DES, has an event rate itself associated with it. And here you see 20% event rate at 2-year follow-up. So you have to balance the risk of PCI with the risk of treating with medication. So where don't we need FFR? Well, I think this patient, 42-year-old, chest pain, anterior ischemia on a stress echo, and this very tight narrowing, you clearly don't need FFR in that setting. If you look at, from FAME-1 data, the relationship between the diameter stenosis, these very mild to moderate lesions, there are some significant ones hidden there, so you do need FFR there. These more severe, 70 to 90%, there are some negative lesions, so you need FFR there. It's really these over 90% where you don't really need FFR, so this is the big area where we need it. Patients who have a STEMI, the culprit vessel is an area where we don't recommend measuring FFR. The reason being is there can be transient microvascular dysfunction that over time improves. So for example, if you have a mid-LAD occlusion and a proximal LAD intermediate stenosis at the time of STEMI and you fix the mid-LAD, we wouldn't recommend at the time of STEMI doing FFR to check that proximal lesion because it may be falsely high. And over time, once the microvasculature improves, you might get a lower value. So you need to use your clinical judgment in that setting. However, in non-culprit vessels, in the setting of STEMI, we do have some good data showing that FFR-guided complete revascularization leads to improved outcomes. And so I think we can rely on FFR in non-culprit vessels. Also, in the setting of unstable angina or non-STEMI from the FAME-1 trial, we have about 30% of patients who presented with unstable angina non-STEMI, and the FFR-guided patients did better than the angio-guided in that setting and had a similar benefit compared to stable patients. So I think FFR is useful in a broad range of patients: intermediate single vessel coronary disease, almost all multi-vessel CAD patients, ACS patients, except the culprit vessel in the acute setting of STEMI, and after PCI to predict outcome. When shouldn't we FFR? Well, if you have a patient with typical angina and ischemia on a non-invasive testing in a region supplied by a vessel with an angiographically high-grade lesion, you definitely don't need FFR there. Culprit vessel of a STEMI in the acute phase. And I think, of course, if the result's not going to change your treatment plan, then no need to do it. Thank you for your attention.
Thank you, Fearon. Last speaker is Professor Jung-Min. He will talk about how do I implement FFR and various non-hyperemic diastolic indexes. So from Cath Lab.
Somewhere? Yeah, we're missing Dr. Ahn.
누가 캣방에 좀 연락해 볼래요? 강의 어떻게?
Then maybe could I ask a question,
Okay.
Dr. Fearon?
There's a question for you, Bill.
Yeah.
Oh, sorry.
He's on direct from the next room. So we must wait a
So-
few minutes. We can
So very nice talk. Thank you very much. So in the last two slides, you very nicely summarized when we should do and when we should not do FFR. But there's a scenario that we may encounter, but which is not included in the two slides, is a patient presented with atypical chest pain, and the nuclear scan shows some ischemia, or especially some mild ischemia. and then it turns out to be a moderate lesion on the angio. So in that scenario, what is your usual practice? Trust the nuclear scan and proceed, or do the FFR? And if it turns out to be negative, it is embarrassing, so what would you do?
Yeah, so that's a great question. I think, you always have to use your clinical judgment, but if you have a patient with atypical symptoms and just a moderate lesion, I would opt for measuring FFR and probably take the FFR result over the nuclear result. I think we are all very familiar with the limitations of nuclear scans and their results. Now, having said that, I do think you need to be careful when you do the FFR and make sure you're doing it the proper way. So for example, you can have some mild apical ischemia and a very moderate mid-LAD lesion that doesn't look that significant. If you measure the FFR with your sensor just beyond that mid-LAD lesion, it may be like 0.85. You want to make sure you start with the sensor in the distal 2/3 so you can get not only the mid lesion but also the diffuse disease that's likely present in that vessel. Make sure you are getting adequate hyperemia, you've equalized. You have to make sure you're not being fooled by any of the pitfalls. But yeah, I would still opt for FFR, and if it's above 0.80, the patient has atypical symptoms and just a moderate lesion, I think we can feel comfortable. We have good data that medical therapy, the patient will do well, and we just have to explain to the patient that occasionally these nuclear scans are misleading and false positive.
Right. Question? No. So Bill, any comments on the previous case, in the live case, about FFR, or Gary, have any comments about the imaging? It's an interesting case.
Yeah, it was a challenging case. I think that, like was mentioned by Dr. Tak, you can have these kinking of the vessel and pseudo lesions. We see that a lot. If you try to do FFR through a Lima graft, for example, into an LAD, you'll often see that, and you can be misled by the pseudo lesions where you'll get a low FFR even though the narrowing's not critical. And then the other, it was a good example of when you have diffuse disease, you're likely going to not get as good an improvement as you would like. And I will say that, I still favor doing an FFR pullback as opposed to a resting gradient. I know there's some concern about crosstalk and some controversy here, but in my opinion, you have a greater bandwidth, and so, you can see the changes more effectively, I think, with the hyperemia, and if there is a small amount of drift, it won't have as big an effect. Now, having said that, it would be nice if we had angio co-registration and the nice display that Philips Volcano has for IFR pullback to do that with FFR, because that would, I think, make people feel more confident in the result.
Thank you. Yeah, because the PDPA was 0.90 or something, so you have 0.1 to play with for the whole pullback. So, Gary, any comments on the imaging side? So you have both you have both IVUS, you have OCT.
Well, first, let me, I find that case very dissatisfying because the stress test was severely abnormal and diffusely abnormal and hard to blame on that distal vessel. That's number one. Number two, this whole thing of kinking is really problematic, and it doesn't matter whether you're dealing with invasive physiology or invasive imaging. It might be something where angio-FFR is clearly going to be better because you're not distorting the anatomy. We don't do OCT of left mains exactly for the reason you saw. Too big, hard to clear, and so on. I found the IVUS imaging to be a little also unsatisfying because the guiding catheter was never disengaged and we never saw what was really happening at the ostium of the left main. But there, it's a case where the invasive imaging and the invasive physiology does not fit the patient's symptoms and the ECG abnormalities. So I'm not so sure we really understand what's going on with this guy. The coronary disease by invasive imaging was really quite modest compared to what the ECGs showed, and the physiology was actually fairly modest compared to what the ECG shows. And the last thing is that LAD disease, diffuseness of disease, you never normalize the FFR afterwards. You can chase it forever, and the strongest predictors of a post-PCI relatively low FFR will be LAD disease older patients and diffuse disease and maybe throw in tapering like we saw here.
I think it's an extremely valuable comment that you made, because we need to consider that a lot of patients could additionally have microvascular disease. This was a hypertensive patient, and we know that even if you have no stenosis or no plaque at all in the angiogram, these kind of patients could have a very significant pathological stress ECG. So it's not helping us with respect to the location of the disease or the target vessel or target lesion itself. We need to have something that more precisely gives us an answer on the individual lesion, and the pressure wire is the way to go for.
I think, clinical sort of scenarios are very important, meaning that after you fix this, as Gary said, it's a little dissatisfying. It's kind of here and there, not really very precise. And if you're not sure, you can always stop and then, repeat the stress test and see if everything is exactly the same. The left main is not simple. That left main is an eccentric lesion, calcium. So you can always fix it later, rather than just automatically fix everything in one setting. Oh, Dr. Ahn is here.
So I already introduced you, so you can start.
Yeah. I'm sorry I'm late. So I'm Jung-Min Ahn from Assam Medical Centers. My topic is how do I implant FFR and various non-hyperemic pressure ratio. So before starting with talking the non-hyperemic pressure ratio and FFR, I'd like to start with a simple question: why we need a functional study? In the Courage trial, comparing with the optimal medical treatment, the PCI did not show the survival benefit and reduction of myocardial infarction. But we have to know some exclusion criteria: severe symptomatic angina and treatment test only positive left main disease, ejection fraction less than 30% excluded. And no benefit was then over using medication was well demonstrated. But even though some patients who have a large ischemic burden, arbitrarily more than 10%, maybe the stenting would be favorable and improve the patient's long-term survival or reduction of myocardial infarction. In addition, this is very old data. The survival benefit of bypass surgery is only observed in patients with early stage treatment test positive or acid depression more than 1 millimeters. But the thallium SPEC imaging negative long-term outcome is very excellent, and even peripheral vascular disease, there was no survival benefit of bypass surgery over medication. Very old data, but at that time, bypass surgery did not show the survival benefit. If a patient treatment test is stage 3, more than stage 3 positive, and stage depression is less than 1 millimeters. So in this patient, revascularization is not necessary. But this kind of stress testing is only 44% of patients underwent stress test prior to PCI. So please, we have to do more stress testing. But this non-invasive functional study has a lot of limitations. Low frequency of performing stress tests, false negative positive result, low spatial resolution, etc. In addition, further resources and experts are necessary. So what is FFR? So how to detect the objective ischemia? During the stress, the decreased blood flow should be associated with myocardial perfusion abnormality, contractile abnormality, electric abnormality. So we order the SPEC imaging or the echo, stress echo or treatment test. What is FFR? Under the hyperemia, we measure the PDPA ratio. The resting status, because of autoregulation, the pressure ratio is not flow ratio. But under the hyperemia, maximum vasodilator, dilation status, ratio of blood pressure can be translated into the ratio of blood flow. So FFR 0.71 can be interpreted as the reduction of maximum hyperemic coronary blood flow by 29%. So the 1997, the initial validation paper presented during the Journal of Medicine, so they made some ischemic threshold of FFR, cutoff value 0.75, comparison with the 3 non-invasive functional study. So we can call it the FFR is a non-invasive functional study in the cath lab. Afterward, many random trial observation trial, they defined the FFR-guided PCI in multivessel disease phase 1, and less than 0.80 FFR value, the stenting is justified. Phase 2 trial, more than 0.80 differed. In those days, cutoff value 0.75. Differing with stenting is more favorable than stenting. But the still current status of FFR penetration is still low. But fortunately, nowadays, some countries, some circumstance, FFR penetration is rapidly increasing. Then what is non-hyperemic pressure ratio? The FFR measurement, adenosine is very important, but sometimes the contraindicated or sometimes disliked by patient, adds cost and time and inconvenience and risk. So 2011, some groups presented the IFR concept in TCT. They have one hypothesis that certain duration of diastole, they call it the wave-free period. So at that time, at that period, the mean resistance is very similar to during the hyperemia. Resistance is very low and constant. At those period, during those period, the PDPA ratio should be very similar to the FFR. So when we determine those period, we can measure the FFR-like index without hyperemia. This is IFR. So this IFR cutoff value 0.89 decided by the ROC curve analysis to predict the FFR 0.80. So IFR is actually not resting index, but the surrogate of FFR. So then minimal resistance of wave-free period is real, but the same groups should have some experimental data. Even wave-free period resting status after hyperemia, myocardial resistance further decreased, even though they designed two random trials, defined flare and IFR sweetheart trial. IFR is they demonstrated that the IFR is non-inferior to FFR. So nowadays, FFR and IFR recommendation is 1A by the European guideline. So after IFR, some companies, some doctors made the pressure-derived non-hyperemic pressure ratios. The DPR, RFR, DFR, at least 2019, we have at least 5 different non-hyperemic pressure ratios. The resting whole cycle PDPA is during the whole cycle. Mean PDPA is resting whole cycle PDPA. IFR, as I already explained, DPR is average PDPA during the entire diastole. RFR is lowest instant PDPA ratio during the entire cardiac cycle, like this. DFR is average PDPA during the period between the PA pressure is lower than aorta pressure and downstroke PA. During this period, mean PDPA is DFR. Is there any difference among the non-hyperemic pressure ratios? We analyze using our big registry, IRIS FFR registry. Compared with the FFR, every non-hyperemic pressure ratio just show that 80 to 85% accuracy. But look at among the non-hyperemic pressure ratios, very linear, very identical, more than 97% accuracy. This is ROC curve to predict IFR of individual resting PDPA, DPR, DFR, RFR. ROC curve is very strange. AUC is more than 0.996, 996, 97. Numerically identical, statistically identical. Yes, to predict the clinical outcomes, Kaplan-Meier curve figure is the same. Then, what is the difference between the FFR and non-hyperemic pressure ratio? There is usually 80 to 85% concordant rate. There is 15 to 20 discordant rate. Important thing is the prognostic outcomes. This is recent our center's data. We'll present it this afternoon. This curve, a red dot and Blue line means discordant group. The red dot means FFR is low, PDPA is high. Blue line means FFR is high, PDPA is low. So FFR is more associated with the patient clinical outcome, cardiac death, MI, repeat interventions. So based on this clinical outcome data, FFR is a better index to guide revascularization. Even in the LAD disease, the trend is the same. Then FFR is good, but sometimes adenosine is very inconvenient. Based on our data, if you use selectively adenosine, the plus minus 0.2 range, then if you use 26% adenosine use, you can increase the accuracy of the diagnosis of FFR of more than 90%. Positive and negative predictive value is more than 90. So this is my final slide. How do I implement the invasive physiologic index? I think FFR is a non-invasive functional study in the cath lab. Non-hyperemic pressure ratio is the surrogate to FFR. Please do non-invasive functional study first, as many as you can, and please measure any invasive physiological study, either FFR or non-hyperemic pressure ratio, unless there is evidence of ischemia prior to PCI. If hyperemic agent is easily available, please measure the FFR. When hyperemic agent is not available or relatively contraindicated, please measure the non-hyperemic pressure ratios, any of those, because all the same. In addition, selective use of adenosine can compromise between the inconvenience and accuracy. Thank you for your attention.
Thank you. So these topics are open to question and discussion to the audience and panelists.
Question from the audience. Yeah.
Hi, thank you. Great talk. I just wanted to ask you, I mean, your data is suggesting that FFR-guided therapy is more predictive of outcomes than, let's say, non-hyperemic indices.
Yeah.
I was wondering if I could get your comments on a paper that was just recently published by the Justin Davies group from, I believe, from Define Flare, where they showed that deferment for LAD, deferment based on IFR, correlated better with outcomes than deferment based on FFR, which is quite the opposite of what you're showing. I was wondering what your comments were on that.
Yeah, thank you for very nice questions. But the different, yes, quite contrasting result. So not yet to explain, but in general, I think when you measure the FFR deferred vessel is more milder than IFR deferred vessel, because we give the adenosine, so small stenosis can be ruled out to rule out the adenosine. So I believe I think it makes sense that the FFR deferred region should be safer than IFR deferred region. But the contrasting result, I don't know why we have the two different results, but we will have a look at further about to compromise two different results. Thank you for your question.
If I add some comment to your question, I think that is the subgroup study of Define Flare adopt. So maybe we can think it as a hypothesis, and so we have different data. One is IFR is better, and one is FFR is better. So I think we must need some more large randomized trials for especially on the LAD lesion, I think, because LAD lesion behave different to when you compare to with non-LAD lesions. And I think the LAD lesion is most important one in the physiologic study. So we need more data, I think. Yeah.
Would it make a difference whether it is diffuse disease or focal lesion? Which one, like the case that we did, or Dr. Dr. Hong did? Obviously, if you use resting indices to judge what you do versus using FFR,
I think it's previous case, IFR is better for the pullback tool to define which one is more severe.
Even though the gradient is very small, like it was
it's very
0.9.
small, but we can decide that. When we compare the reason severity in the multiple sequential lesion, IFR, I think I prefer IFR.
Yeah. I'd like to make a comment on the FFR. Actually, FFR has a very sound scientific and mathematical background, the best tool to assess the physiological significance. But I'm worrying about the oversimplification of use of FFR. Just the cutoff of 0.8, actually less than 0.8, even less than 0.75, does not mean ischemia at all the time. But it uses like this. In the beginning of the NEJM paper by Dr. Piles demonstrated that over 0.75, any over 3 tests didn't show the positive ischemia. That means 0.8 or 0.75 over that criteria, that there is no ischemia, you can safely defer the patients. But lower than 0.75 or 0.8, there is ischemia, but not necessarily there is ischemia. So even if you can find the 0.7 FFR, it does not indicate that you need to treat the lesion. Is that correct? So
yeah,
I'm worrying
correct.
about oversimplification.
I totally agree with Professor Kwon's opinion. So the benefit of FFR-guided PCI is to avoid unnecessary stenting, not put the stent if there is FFR value is lower than 0.80. So aim to try justify the stenting if a lesion is lesion FFR is less than 0.80 to reduce the spontaneous myocardial infarction marginal significance. But this is not means that FFR less than 0.80 means the ischemia. But I want to say FFR is more than 0.80, don't touch and don't put the stent. This is the main message.
Any other comments? Otherwise, we'll. Right. Thank you so much. We'll wrap up. Finish? No. So I think we're going to wrap up this session a little early. So thank you very much for everyone for staying and for a very sort of interesting and complicated, somewhat case and great discussion as well. Thank you.